Morning all, and good afternoon, Prof. Cyrus. Welcome to this lecture, and we are very happy, we are very delighted to have Prof. Cyrus this morning. And this morning he will give a lecture. The topic is the team steps, a comprehensive approach for safety and communication for patient safety. And before Prof. Cyrus giving us a lecture, I would like to read his CV. But actually, if I read the CV, it's quite long, but I'd like to make it shorter. And Prof. Cyrus Engineer he is the senior staff academic program of the Department of International Health of Johns Hopkins Public Health, and is a management expert over 25 years expertise in building capacity for the quality, patient safety, and performance management system for teams and organizations in diverse international setting. And he also led the large monitoring and evaluation project in Afghanistan, a country director, and has held leadership position in hospital with India. And he has experience led a global campaign from WHO to reduce healthcare associated infection by promoting hand hygiene and a patient safety initiative. Okay, everybody. Prof. Cyrus, can you hear me?
Yes, Professor. Thank you so much for the kind introduction. Okay. Can you hear me? Can everybody hear me?
Yes, I can hear you clearly. Yes, time is yours, please.
All right. Thank you so much. Thank you for the generous introduction. I'm trying to, hello, everybody. Good morning. Good morning. I hope you've had breakfast.
Good morning.
Good morning, sir.
It's early morning.
Good morning, sir.
Good morning, sir.
Good morning. Good morning. Good morning. Okay, so let me see if I can manage to do something that I mess up usually. Let me see if I can share my screen. Are you able to see my screen right here?
Yes, I can, sir.
Yes, sir. Yes, sir.
Is that, can you see it?
Yes.
Yes? Okay. All right, so let's roll. So welcome back, and I'm happy to be back with you all again to continue the journey on patient safety. What we're going to discuss today is a program that everybody can implement in their organizations to improve patient safety. I'm going to discuss the origins of this program and how Johns Hopkins actually implemented it. This is after the Josie King. I showed you the video for those of you who were there last time. I showed you a video about a small 18-month-old baby that died at Johns Hopkins in 2001 because of dehydration and misused narcotics. And so, you know, the mom, you heard the mom speak at one of the sessions, and this was a program that was developed right after. So what are we going to discuss today? We are going to talk about culture because we spoke about culture, at the last talk and why culture is important. So the first part of the session is, what is culture? How does it matter? Does it matter in patient safety? What have we learned from other industries that have learned the hard way about culture and why we should focus on culture? The second is, and what are the factors that influence culture? How can we measure culture in an organization? How can we measure culture in an organization? So that's the first part of the talk today. The second part is, there's different types of work that leaders do. You are all leaders, or someday some of you will be leaders in departments and units. There are nurse leaders, there are managers, hospital managers, and at some point you're going to be leaders. And so leaders wear two hats. You have the technical work and you have the adaptive work. They are two concepts that I want to introduce to you and why both of them are equally important. And the third aspect is, of course, what we are here for is, what is this comprehensive unit-based safety program? Where did it start from? How did it evolve? Well, how do you roll it out in an organization? How does it help improve patient safety? How does it help to have conversations about patient safety? And then some applications and evidence that it actually works. Is that okay? Does everybody think this seems like a good use of your time? Yes? Okay, good. Hopefully we'll have some time for questions at the end. So make a note of all the questions that you have as well. So with that, let me start with the question. We talked about culture, right? We talked about culture. So what exactly is culture? What do you mean by culture? What is culture?
Norm, values,
Maybe habits or
Habit,
what people did you do, what people do,
right? What people
everyday activities.
Perfect. Activities, what people do, their habits is very good. This is actually a definition of culture. It's a set of values,
yes, values.
guiding beliefs. What are the beliefs that are there and understandings that is shared by members of an organization and taught to new members. So it's basically values, what's important, that how we communicate those values, those beliefs, and how it is shared by members of an organization and how you teach that to new members. Yeah, it's typically like at home also. If you have culture of like I have a teenage daughter, and so we have a culture of eating at the dinner table together. There is a certain bedtime. How do you respect your elders and so on? So these are guiding beliefs, practices, and values and norms within an organization, but it's also within a family, what you respect and what you regard. So the important part about culture is it does not happen overnight. It's not something that you turn on the light bulb and ta-da, there's a new culture next morning. No, that's not how it happens. It's shared and learned. And you have to role model practices. So as a mother, as a parent, if you want to set a certain culture in your home, you have to role model that. So it's shared and people learn it. They watch you and they learn it. It's a slow process. It evolves slowly. It's almost invisible. You can't see it as much. It's the soft part of organizations, not the hard part, the soft part, which people often say, doesn't really matter. And it also guides behavior. Okay, so this is what one of the definitions of culture is. But I like another definition. That is more simple and easy to understand. And that is the way we do things around here, right? This is how we do things around here. If you come to my hospital, if you come to my institution, this is how we do things around here. So the important thing to note is one attitude basically is an opinion. If it's one person, one employee's attitude is an opinion. But when everyone's attitude is what we call culture, sometimes culture is also referred to as climate, organizational climate. So if you look at studies, you might miss studies if you just type in organizational culture. Sometimes you need to say climate, organizational climate. So I'll stop here. I want to make sure that I'm not speaking too fast. I'm okay. You can hear me. Can you just give me a thumbs up if that's okay? If you can hear me, my pace is okay. Am I going too fast?
No, sir.
Is that okay? Yeah, just to be sure. Okay. If I am going fast, if I am what you call rushing through things that we need to slow down, please don't hesitate to let me know. Okay. Is that all right?
Okay, sir.
Okay.
Yes,
Okay. So I don't know how many of you what you call remember the space shuttle Columbia that actually there was an accident and 7 astronauts died when they were on a mission in space. And the headline of the newspaper, after a long assessment of what happened and what went wrong, they blamed NASA, which is the premier agency for space and aeronautics in the United States. They blamed the safety culture. So the idea was that it wasn't a small problem, but it was a systemic problem that was linked to a safety culture at an organization that focused heavily on safety culture. But at some point in time, their safety culture was not what it was when they started. So I don't want to spend more time on what happened with Columbia, the space shuttle disaster. But there was the space shuttle that's disintegrated. For some of you who might have what you call, might not know, there was a space shuttle with astronauts on a space mission called Columbia that was re-entering the Earth's orbit. And 82 seconds, a piece of foam struck the leading edge of its wing at about 650 to 950 kilometers per hour, making a hole in the tiles. And then after that, it actually, when it was re-entering, it melted because that foam was insulation. And because that foam piece fell off, it burned the wing, and the pilots could not control the spacecraft, and therefore it blew up in a few seconds later. So if you look at this report, and this is a web link to that report, the report does not blame technical flaws, but it blames the culture at NASA, which was earlier, we will take pride in quality, we'll take pride in what we make, and we will test everything to, let's try to get people into space, let's, what you call, contract things out to other people. And so the safety culture was blamed right there. So that's about NASA. But I'm sure you all know about, the Boeing 737 MAX. I'm sure you heard about it. There was, because this happened in Indonesia, right? There was a plane on October 29th, 2018, a Lion Air flight, which was, which departed from Jakarta to Pangkal Pinang, I hope I'm pronouncing it all right, crashed with about 189 passengers. The pilot had a lot of flying hours, a lot of experience, and so clearly there was something wrong. But then that wasn't the only incident. There was another incident that happened with the same airplane when an Ethiopian Airlines flight 302, which was headed from Addis Ababa to Nairobi in Kenya, that crashed with 157 passengers. And then there was a large, what you call, investigation with the committee, with the FAA, with congressional hearings in the United States, and a large report. And the report said, there were things that were wrong. They were trying to rush through. They were trying to cut corners. And, they did mention about the culture, not directly the culture this time, but they said there were production pressures. They wanted Boeing to manufacture more aircraft because Boeing had lots of orders. So you can see the quote that has been reproduced below directly from the report that said it had several unmistakable facts. The MAX crash is not the result of one single technical flaw, but it was technical mistakes or mismanagement. They were a culmination of a series of technical assumptions by Boeing's engineers, a lack of transparency. And this is a cultural aspect, how transparent you are when you report that this safety or security system, that upgrade is not working, and that's a culture. Are you allowed to speak up and say, this technical safety feature is not working, because there was a technical upgrade, a software upgrade that actually led to what happened. So, but there were transparency issues and insufficient oversight by FAA, which is the Federal Aviation Administration in the United States, because they did not know. So Again, this has a lot to do with culture. And the reason I'm saying that is because some of the industries, as I showed you last time, have made huge leaps in improving safety and quality, but this was a failure. And as you all might know, Boeing is having a hard time. Its stock price is plummeted from what, $400 to $600 per share to now what, about $140 to $180 per share. Is having a hard time getting all that reputation back. So, and this is only with 189 passengers and 157 passengers, right? 2 crashes. I showed you data just in the United States in the last session, that in the United States, we have about 100,000 people dying of medical errors each year. 100,000 people dying of medical errors. But it's a hidden epidemic. It's not something like what you see right here, where everybody dies at the same time and the press and the media take note of it. Yeah. So again, these are just 2 examples. There are many more examples where culture has played a role. But the important part is that there is a benefit and there's a purpose to culture, because culture influences employees to work, act, think, feel, and behave in a certain way. And it helps employees figure out what to do in situations when there are no rules, standards, and policies. It just helps you become part of the family and not make mistakes and fit in with the family, if you know what I'm saying here. It's just like at home, people know what is acceptable, what is not acceptable. Can I go out alone after 11 p.m. at night? No. What time, what is curfew hours? When do I need to come back home before dad yells at me? Things like that, So it sort of helps the organization. So there are lots of factors that influence culture. So this is a model that shows how is culture informed. Yeah, what are the factors that influence culture of an organization? So I don't have enough time to go through this, but I'll focus on a few right now in the interest of time. But laws outside, how tight those laws are. Do you punish doctors and nurses who make mistakes and things like that? The external laws and standards, they govern culture, what organizations do. An organization's mission, why do I exist? An organization's structure defines culture. So let me stop here. How does an organization structure of an organization, influence culture? Let me ask you that question. Does anybody have an answer? A structure of an organization. We talked a little bit about hierarchy at the last, does hierarchy have a role in culture?
Can you repeat your questions, Professor?
Sure. What I'm saying is my question is, when you look at an organization structure, does that have anything to do with culture? When you look at an organization structure, how many levels, who is reporting to whom, etc. Does that have anything to say about culture?
Yeah.
How people will behave in an organization? Yes, it does.
Let me translate it first, maybe. Yeah.
Sure.
Jadi Bapak Ibu, Prof. Cyrus bertanya apakah struktur organisasi ini ada hubungannya dengan budaya begitu. Mungkin Bapak Ibu bisa menjawab. Bahasa Indonesia tidak masalah, nanti kami akan terjemahkan.
Saya mau jawab, mungkin Bapak.
Silakan, mau langsung bahasa Inggris juga boleh.
Mungkin bahasa Indonesia boleh. Dulu nggih Pak, soalnya
ya, silakan.
Sebenarnya mohon maaf Bapak Ibu belum bisa menyalakan kamera karena kendala jaringan. Menurut saya suatu susunan organisasi atau hierarki organisasi itu dipengaruhi oleh budaya. Untuk di Indonesia sendiri dipengaruhi oleh budaya karena kenapa? Di Indonesia itu banyak budaya seperti menghormati orang yang lebih tua, menghormati orang yang istilahnya memiliki kedudukan lebih tinggi dari kita, Pak. Jadi menurut saya suatu organisasi itu pasti juga dipengaruhi oleh budaya karena pada sebuah organisasi yang paling atas itu pasti yang memiliki pengalaman lebih, yang memiliki pengetahuan lebih. Jadi seperti itu, Pak.
Oke.
Dipengaruhi.
Oke, saya terjemahkan dulu ya. Ya, terima kasih Pak Raffi Abiyu ya.
Mahasiswa, mohon izin Bapak belum
Ya. Oh, Pak Raffi Abiyu ya. Professor Cyrus, according to Mr. Raffi Abiyu Mukti, told us that yes, the organization structures is related with the culture, and both are influencing. And why is that? Because like in Indonesian culture here, the elderly people should be given respect. So the elderly or experienced people should be put on the top rather in the inferior of the structure. That is the answer, Prof. Cyrus.
Excellent. Thank you so much. And that is exactly what I'm saying. When you walk into an organization, how people sit, how people talk, how formal or informal people are, what is rewarded, what is not rewarded, who gets punished and who gets promoted, what is the language and the tone of the leaders, are there cubicles or are there separate offices? Can you walk into somebody's office or do you have to send an email or make a phone call or make an appointment? All of that influences culture. Yeah. So this is basically the whole model of what influences culture, what you beliefs, values, and norms of employees, beliefs, values, and norms of informal leaders, beliefs, values, and norms of formal leaders. The physical work setting, is the boss sitting in a ivory tower on the 30th floor in a New York building, or is he or she among many other people working side by side with them? What are the stories that people remember about the organization, which the organization keeps repeating? This employee did that, and that employee did that, etc. So these are all aspects that influence culture. Yeah, that's what I wanted to say. These are the factors that in an organizational structure, if you have many levels, yeah, many levels before, like 7 levels or 8 levels, there's the president, there's the vice presidents, there are the senior directors, there are the directors, there are the senior officers, there are the officers, there are the junior officers, there are the coordinators, huge hierarchy. It is telling you something else versus a flat hierarchy where there's only 3 levels that are reporting to each other. Yeah, IT organizations don't have very large hierarchies in hospitals and healthcare. We have many, many layers right there. So that also tells you something about the culture in an organization. So I just wanted to spend some time because this is an important aspect when you design organizations, when you design systems, when you design processes, when you design for safety. If you're punishing people who are making mistakes, the culture that we are setting there is that of a punitive culture, a culture that does not encourage people to speak up, right? And so that's an important aspect. So we finished the first part of the presentation. We are a little behind, but I'll try to catch up. The second is technical and adaptive change. So every one of us, when we are put in leadership positions, have to wear 2 hats. We wear 2 hats. One is the technical hat, and the other one is the adaptive hat. So we are wearing 2 hats right there. So the technical hat is the clinical leadership that we have, the competence and the knowledge in which we are trained. Yeah. So as a nurse, your clinical skills in the nursing profession. As a physician, your diagnosis and treatment skills as a physician. Yeah, but there's also an adaptive hat that you wear. And so let's understand that for success, for safety, you need both the technical as well as the adaptive. Yeah. So one of the most common mistakes, leadership mistakes, is expecting technical solutions to solve adaptive problems. So what are these adaptive problems? I'm going to give you an example. Is that okay? Yeah. So when I was the CEO of a hospital, we had a very, very wonderful ICU nurse manager. She was a leader. She was a nurse manager. She would be good at scheduling staff, ordering supplies, making sure that patients were taken care of properly and all that. So she was a nurse leader in the ICU. She left. She left because she had a better job opportunity in the Middle East. So she left us. All of a sudden, I had to find somebody to fill her position, right? So what I did was I thought I made a good decision. I asked one of the other nurses who was experienced, who was with us for many, many years. I called her and said, would you be so kind as to become the manager, the boss, the big boss of this nursing unit, right? We'll pay you more. And because getting somebody from outside, new culture takes time, ICU is an important area. So I said, let me promote from within. After a few weeks, she came down to my office. She was crying, actually. She was sobbing. And she said, I really want to leave this hospital. I want to leave my job. I said, what happened? You should be happy. We give you a pay increase. You have a better rank. She said, I was doing mostly technical work, and suddenly you put me in a leadership position where I had to schedule my colleagues, my peers, my friends with whom I used to have lunch, with whom I used to go to movies. Now they think I'm the boss. They don't want to speak to me. They don't want to go shopping with me. They don't want to talk to me. They think and I don't know how to budget. I don't know how to do the financial. I don't know how to solve problems. I don't know some of the communication stuff that I need to know. I've just been trained as a nurse, and you put me in this role. And so that's what adaptive work is. Adaptive work is not technical work, but it is skills that you need to manage relationships, manage people, to be able to understand. It's also what we refer to as emotional intelligence. So in order to be, there's adaptive work. And so the program that I'm going to talk about today, the CUSP program, is a combination of technical and adaptive work. In other words, it's just not the technical work, but it combines both the technical and adaptive, because in order to succeed, you need to know both the technical and the adaptive work. So giving you an example, the technical work is there is knowledge to implement a solution, and that is all the patient safety tools that you have been trained in, and all these tools are available. But the adaptive work is all about the culture. It's all about understanding the organization. It's all about managing change and so on. So that's the adaptive work. So this program says that one cannot be successful just with technical work. One needs to also understand the adaptive components of the work. So the 6E framework is what we use for adaptive work. You have to engage, you have to educate people, you have to engage people. You need to win the hearts and minds of your teams. You can't just say, do this and expect them to complete. That's all adaptive work. And it's easier said than done. How hard do you need to work to win the hearts and minds of somebody at home, your family? You have to work really hard. And in an organization, you need that real passion and commitment to win that. Then you need to educate them, not just say them, here's the manual, go ahead and look at that manual. You need to teach your teams about your intervention. You need to just get them engaged. You need to get them to understand why it's important. Then you need to execute that. Then you need to evaluate who is on board, who's not on board, what processes have improved. And one of the things that people often realize and they make a mistake is, if it does not work, let's just throw this off. It's not working. Let's just give up. No, there's the E, which is the 5th E, which is called endure. You got to talk, you got to coach, you got to monitor, you got to step back, you got to adapt your strategy. So that's endure. And then of course you expand, you scale up. So that's all what adaptive work is all about. And that's part of the process. So we are almost at halftime, 4 minutes later than what I expected to be, but let's talk about what this program is all about. Are you ready for that? Yeah? Am I going too fast? Are we okay in terms of pace?
Yes.
Yes.
Okay, sir.
Okay. Okay. All right. So this is a program, the Comprehensive Unit-Based Safety Program, that took birth at Johns Hopkins after Josie King, that 18-month-old baby, died in the year 2001. Okay. So, and then after it took birth, it was adapted at Hopkins for many years. Then it went to the National Agency for Healthcare Research and Quality. It's called ARC, which is the leading agency in the United States for quality and patient safety. And so that's the agency. So it was further adopted by ARC to disseminate it, to improvise it, and then to send it across to the entire country. And this CUSP program includes a lot of tools, safety tools and approaches. So today I'm going to talk a bit about this CUSP program. That does include improving teamwork and communications, one of the things that we thought we would talk about earlier about team steps. Okay, so I'll talk to you more about each of these, what you call. It's based on the understanding that all culture is local. Okay, you say, what is organizational culture? When I ask people, what is organizational culture? Organizational culture is the sum of all the subcultures, all the cultures put together. That is organizational culture. But culture is local. One department where in laboratory will have a very different culture from a department in radiology to surgery to what you call medicine, right? They may all have different cultures. And so culture is local. The program is to improve culture, and the culture must be owned at the unit level. So it's called CUSP, Comprehensive Unit-Based Safety Program, because it acknowledges that the unit culture is local. It's a family, it's an independent unit. So you cannot broadly look at culture as organizational. So believes that harm is not an acceptable cost of doing business and patients in healthcare. You don't want any harm, you want zero errors. And this program can be applied by anyone, anywhere. That's why I thought this would be most relevant to talk to you about, okay? So what is it broadly? It's a strategic intervention, okay, that provides a roadmap to learn from mistakes. You learn from mistakes, you improve safety culture, and you improve systems to make them safer. So if I was to summarize CUSP in one sentence, just one sentence, this would be the sentence. It's a journey or a roadmap to first learn from mistakes. So to learn from mistakes, it encourages you to speak about mistakes, yeah? To improve the safety culture, more teamwork, more communications where things can go wrong, when things go wrong, just like this is all from aviation industry. They talk to each other and improve systems to make them safer. So it's a 5-step program that can improve the safety culture by empowering staff. It is by empowering, you know what that means, right? Empowering means giving more ownership to frontline staff, nurses, not just physicians, but nurses and other healthcare professionals who are involved in the patient care to assume responsibility for the safety in their environment. Okay, so that's what it is. It helps. How does it work? By increasing education and awareness, making people access organizational resources that are otherwise not available, and providing tools to improve. Okay, so that's how. So what is CUSP? It's a strategic intervention. It's a 5-step program. And this is how it's done, by increasing education and awareness, enabling access to organizational resources, and I'll talk to you about all of this in a bit, how it happens. So are you excited to understand what this is all about?
Yes, of course.
Yes.
Yes, sir.
Okay. So the goals of CUSP is to improve patient safety, to improve safety culture, which is the adaptive work that we talked about, and to integrate safe practices in daily work, not see it as something outside, something additional that you need to do. So it's to include all of this in the daily work. It's a 5-step framework. And the most important aspect, it's not like implemented at organizations. The whole organization does not need to adapt it at once. No, 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 no. You can start with 1 or 2 units. You can start with maybe 1 unit in your hospital. You don't have to start with everybody. So it's not like many other programs are, you have to implement it and it has to occur everywhere. That's not what it is. It's at the unit level. The unit being defined as radiology, laboratory, medicine, etc. And then it's a cyclical process. It's not linear, which means we'll see how that is, okay? So before you start the work, there are some things you need to do. If you want to get onto the CUSP journey, you have to do a few things. This is important. The first step is extremely important. Your leadership in your institution should buy into this model. So we need to talk to the leadership what this is, what benefits. And for that, you need to make sure you understand it very well when you present it and how it works and what has been its impact. What's the evidence for this? And because at the end of the day, leadership drives change. And so it's very important to get real leadership support, not just, yes, I think it's a good idea, please go ahead. Then you need to do an interdisciplinary team within the unit. You need nurses, doctors. So in a unit, any unit that you have, you need doctors, nurses, healthcare providers. In that unit, you need to have a team that wants to improve. Then you have an executive of the hospital or somebody who's in a senior leadership position who actually adopts that unit as his or her baby, adopts it. Like, this is my baby. I'm going to improve safety here. It can be anybody. It does not need to be a chief medical officer. It can be a chief information officer. It can be somebody else. And then, of course, you need to, if you want to improve culture, you need to know where the baseline is, where you are at the start, right? So you need to conduct a safety culture assessment. And there are many tools, I can talk about them, that you need to, you need to do an assessment of the unit, of what is the culture right now? Are people, what's the teamwork? How do people communicate? What are the values? What are the relationships? Do people speak up when there is a mistake, yes or no? And so on. Am I going too fast?
No.
Okay. All right. So this is pre-CUSP. Before you start on the journey, this needs to occur. Before you got to have leadership that is signed on. You need to have an interdisciplinary unit team. You need to find somebody. We'll talk about that, and we'll talk about who is going to adopt that unit and say, this is going to be my baby. And then, of course, you're going to do a culture assessment. Okay. So as I said, there are lots of tools available, and they are free for download. Not just you can download them for free, but you can actually, there are analytic files, so you can apply those files to come up with the culture of your unit. So culture, these are some examples. This is the safety attitude questionnaire. This, of course, you have to pay for now. It was free earlier, but ARC and many other institutes have free downloadable forms and guidance on how to measure culture in your unit or in your hospital. And I can provide information if anybody is interested, where to get all these tools from. But this is just an example. How do you define as the safety climate? How do you define, I would feel safe being treated in this clinical area? This is one of the questions. Do you feel, I would feel safe being treated in this clinical area? So if you look at safety climate, safety culture, do people feel safe? in your unit. So so the example items that you will check is how I would feel safe being treated in this clinical. I myself, if I'm admitted, I would feel safe, or medical errors are handled appropriately in this clinical area. So, so that is a nice instrument to sort of come up with the safety culture of the unit. And there are many instruments, okay? So at Hopkins, we did this in 98 departments, in 98 areas in 2 years, and less than 60% of the respondents reported good climate. You know, they were asked, is there a safety climate? I gave you that example. Is there a teamwork climate? And, you know, on 2 occasions when this survey was done, higher is better. You want higher climate, safety climate, you want higher teamwork climate. This was done way back in 2004 and 2007, but this is data that is from our hospital. And even in that hospital, people say, we don't have a good culture for patient safety, and we don't have a good culture for teamwork, okay? So that just shows you. So just so you know that when you look at linkages of culture with outcomes, clinical outcomes, are they linked? So you don't want to invest in a program to improve culture if there is no linkage, if there is no evidence with outcomes, clinical outcomes. So there is evidence in the literature that having a good culture is associated with better outcomes, okay, for patient safety, for patient quality, also reducing absenteeism, people not coming to the hospital, nursing turnover, nurses leaving the hospital if there is not a good culture, you know, and so on. So there is a lot of evidence out there about the linkages of culture with clinical and operational outcomes. So culture has they say culture is like a rope. So you have technical, you know, you have a rope that has, or a braid that has 3, culture is one of the parts, and so it needs to be sort of blended in. So it's a very simple program. It is not fancy, it's not sophisticated, not rocket science. It's very straightforward, which is why I wanted to talk to you. Almost everybody can use this program. All the material is available for free on the websites, and you can download it step by step how you can do it. So I may not get into all the details today in the interest of time, but I have all the information that you can access, and I can show you where to access it. But these are the 5 steps. The first step is educate the staff in the unit on the science of safety. The second step is you identify defects, identify problems. The third is what I mentioned, is you have an executive to partner with the unit. You want a senior executive like a vice president, a president, a director who says, this is my unit. And then the fourth step is you learn from 1 defect per month or per quarter, depending on your capacity. Every month or every 3 months or every 4 months, we will make sure that we agree on 1 problem and we fix that 1 problem from patient safety. Yeah. And then you implement teamwork tools. That is the team steps part, so that you increase teamwork and so on. So these are the 5 steps. So each of these steps, I can send you these slides if you would like, or these are already recorded. I mean, so you have, so the first is the science of safety education. So what is it? The science of safety is telling people mistakes happen. It's not your fault. It's the fault of the system. In healthcare, we are complex, we are messy, and so don't feel bad. Here is why mistakes happen. It's okay to to understand that mistakes, and it's okay to acknowledge that mistakes happen. And then after doing that talk, as soon as once that talk is done, you distribute the culture survey, yeah, which we talked about earlier. You distribute to the culture survey to all the people in that unit, yeah, and they complete the culture survey, and that is collected by somebody. So that's the first step. The second step is then you identify defects, okay? You want to, people say that the people at the bedside know all the problems, why they happen, and what needs to be done to solve the problem. It's called the wisdom of crowds. It's the wisdom at the bedside. But still, what we do is executives and managers who are paid a lot of money try to think about solutions to a problem that they don't understand well without asking. And so the important part is to ask them, how is harm going to occur in this hospital? What are the ways harm occurs? And so that is what you do. You engage and empower staff to speak up and say, and there is just two questions you ask them. You ask them two questions to identify the defects, and these are the two questions. Okay. The first question is, please describe how you think the next patient in your unit area will be harmed. It's a small piece of paper. Yeah. And the second is, please describe what you think can be done to prevent or minimize this harm. Two questions. How are you going to harm the next patient in your unit? And what do you think can be done to prevent the harm? Now, the important thing is, you want people to feel comfortable speaking up. So you don't want them to put their names if they don't feel comfortable. It can be anonymous. They don't need to write their name. They can just give this slip. And that is a wealth of information. It's like asking the air hostess, what are the problems? Which are the parts in the plane the pilot does not know? The pilot is all at the front. They don't know what's going on behind and what might be the issues. But he's asking people about how harm is. So this is the two questions which they turn in. So the first step is the safety culture survey. You get a baseline of the culture. The second step is you ask them to identify defects. Somebody collects all these slips from all the members, analyzes it, and who is independent without the names of the people, and they know what harm is going to occur in that particular unit or what types of harm that is going to occur. And the third is what I mentioned. You need somebody who cares and who's the father or the mother or the parent of that unit. So you want somebody who works closely with that unit to take their problems and amplify their voice and have access to resources that otherwise would take a lot of time for that unit. There are times when the lab says, we know what the problem is. We have said this so many times, but there is nobody to listen to us. That is the problem that we have, because remember I showed you in hospitals, there is a lot of hierarchy. You tell the boss tells somebody, sometimes it just takes too long. And so we want to shortcut that process. And to shortcut that process, you have a senior executive partnership. You have the big bosses who know nothing about clinical care, but at least they are, they may be a chief information officer. It can be a vice president of human resources. It can be somebody else who becomes the senior executive partner and who adopts that unit. Not only do they adopt that unit, but what they do is they take patient safety rounds. They go and meet with that unit once a month. Every month they meet with the people there. They look at the results and they talk about the issues and they find out what's going on. Okay. And then these leaders then take this to their bosses or to other people. So if the unit needs a small equipment to improve safety, and it's just like $100 or less than $100, and they are not getting it, and their voice is heard, and he can authorize or she can authorize it, and they can buy these things. Okay. And so they do walkarounds. So they walk around. It's like a leader taking a walk, talking to them, talking to all the frontline leaders. The purpose is to strengthen collaboration among senior hospital leaders, department chairs, and frontline caregivers. So there's more communication. Okay. The end result is, of course, the leader takes ownership for that unit. Okay. What are the type of questions that the leader asks? When they're going on this round, what are the type of questions? here are the types of questions that the leader can be asked. So this is all the leader is prepared. They don't know, how have you prevented a patient from being harmed in your unit? What keeps you up at night? This is my favorite question. Okay. What keeps you up at night? You can't sleep because you are worried some patient will die or will not get the treatment that they need. What bothers you after you have left the hospital? When you left the hospital, what keeps you worried? Yeah. How will the next patient be harmed? What are some barriers you have faced in patient safety? This is another one of my favorite questions. If your loved one was a patient in this unit, what would you be worried about? You know, and many times I get good responses on this question. If my child was to be admitted to this unit, you know, you almost always, there is a personal connection with some of these questions and some of them speak up. And how can you better involve patients and families in their care? So these are the kind of questions that the executive asks when they do the walk around, when they every month, once a month. And then the step 4, first you do the baseline culture assessment, you identify defects, you analyze the defects, you have the executive, and then the next journey is to learn from these mistakes. You know that these defects are going to occur. And so the goal is you try to sort out the problem, you try to address the problem. So you identify the safety defect, and your goal as a unit is to investigate at least one defect. Sometimes it's per month, sometimes it's per quarter, depending on the capacity. Okay. And usually, along with the executive coach, you have somebody from the quality management and patient safety team who is trained in data analysis, Six Sigma, Lean Sigma, etc., who's called a safety coach, a patient safety coach, who is part of this team. So the executive, the patient safety coach, and the members of the unit, they together want to learn from the defects that are occurring each month or each quarter. So here's what, when there's a mistake that occurred, they talk about it openly. They talk about it. What happened here? Why did it happen? What could you do to reduce the risk? How do you know the risk was reduced? So these are the questions that they are. So if somebody gets hurt, if there's a wrong blood transfusion, if there's a wrong side surgery, what happened? Why did it happen? What could you do to reduce the risk? And then afterwards, what do you do? How do you know the risk was reduced? So this is learning from defects. So it's a continuous quality improvement, continuous patient safety improvement. I don't know, how are we doing on time? We are almost out of time, but I'll be done. I promise you, I'm almost there. So there are teamwork tools. There are lots of tools that come along with us to improve communication. And Team STEPPS is one of those tools. So Team STEPPS is more for teamwork and communication. And so a lot of tools come with this. So that is step 5. So this is just an example of what is good teamwork and communication. When you ask a doctor and when you ask a nurse, the answers are totally different, at least at Johns Hopkins. I don't know what it is in Indonesia. When you ask a doctor, what is good teamwork and collaboration? They say good collaboration means the nurse does what I say. And when you ask a nurse, what is good collaboration? Good collaboration means I'm asked for my input, right? So there are totally different ways of interpreting what teamwork is. So that is not teamwork, clearly. So this is how CUSP works broadly. At the unit level, you have CUSP teams. At the department level, you have a CUSP facilitator. And at the institution level, you have a CUSP program coordinator. So you have a CUSP program coordinator, you have CUSP facilitators that are coaches that look after different CUSP teams. So there are lots of CUSP teams, and you can slowly grow from 1 unit to 3 units to 5 units to 7 units and slowly add the capacity. Okay, so it's a continuous journey. You repeat a few steps. When new staff join, you do the training and the science of safety, and you share results and successes. There's a lot of evidence. We don't have time to go through it, but I can share all the papers about CUSP, which you can use to disseminate, but I want to leave some time for questions. But pre and post CUSP, there have been a lot of studies. These studies have been done not only in the United States, but in different settings across the globe. And it's a simple program, does not cost much, does not require technology, does not require what you call a huge amount. It just requires investment and training. Okay. This was at Johns Hopkins. After implementing that, they saved $7 million because they reduced the length of stay in the ICU by implementing daily goals. They reduced, through 654. This is another example of bloodstream infections in the United States. How it reduced when they implemented CUSP along with some of these interventions. So the boxes that you see are technical interventions, but CUSP was the adaptive work that carried these technical interventions and made it sustainable. So bloodstream infections were zero, what you call much lower. So that's what you see. This is safety climate at over 100 clinical areas at Johns Hopkins, before and after. This is before CUSP and after CUSP. This is across 100 clinical areas. So we measured safety culture in departments, and each one of that lines, histogram bars represents one unit. And we have marked some before and after CUSP, and you can clearly see these are ICUs, Weinberg ICUs. WICU is the Weinberg ICU, which is a cancer ICU before and after. The surgical ICU is the SICU before and after. So you can see that CUSP seems to work in improving safety culture and safety climate. Okay, so I've talked about what results. There's engagement of staff. People are empowered because they get to speak up. So all the frontline people, nobody listens to them when they're speaking, nurses and healthcare workers. It's just like, I listen to the doctor knows best. But here they get a voice, they get to speak up. And then senior leaders also get engaged. There's more communication and more discussion. It's open, it's not punitive. People are not blaming each other. You can write things down and nobody is affected. There's some shared mental models. And then of course you collaborate and focus on systems rather than people. So if you want to know more about this program, there's a video, there's a link. It is adapted nationally. I can share all the information. I can share all the papers about success. It has been used in everything from patient falls to surgical infections to bloodstream infections to everything that you can, medication errors to. It's known to improve. So you've got the important thing that I want to say is that no one goes to work intending to make a mistake. No healthcare person that at least I know wants to go to make a mistake intentionally. And if they made a mistake, they feel very bad. They feel extreme guilt after the event. Yeah, after they harm the patient, they feel bad. They don't want it to happen in the first place. They don't talk about it, and they can't talk about it because of professional autonomy, professional pride, professionalism. But internally, it eats them up. They don't like it at all. So what do? It's basically to catch it before it reaches the patient, and that's what CUSP is all about. So I want to say thank you for being so patient with me. I am done with by giving you an orientation, and I want you to say take care and stay safe. And I'm happy to take a few questions if we do have the time. Thank you.
Okay, thank you, Professor Cyrus. It was a very interesting lecture, and I'm very impressed with that. And as you know, I'm a chief of the program of the quality control and patient safety in the academic hospital, and it's quite challenging and quite hard to make a safety culture in the hospital. And you enlighten me how to improve the situation. Thank you very much. I would like to ask the audience, and up to now, there are 463 participants. It's a huge amount of participants, I think. Anyone want to ask Professor Cyrus?
May I ask a question?
Yes, please, Miss
Yes.
Rara.
Yeah. My name is Rara.
May I ask a question?
Before that, I want to say thank you to Prof. Cyrus for the presentation. And may I ask a question about the culture? Uh, can a culture could be harmful to us or an organization, especially to the safety itself, like patient safety or other safety? Thank you.
Yeah, I think good question, Rara. If yes, as I mentioned, culture can eat strategy for breakfast. What does that mean? An organization leadership may have a very good strategy, yeah, but what might happen if you don't have the right culture, it can overtake the strategy, and it may not allow the strategy to be implemented. So in the United States, I can give you examples where um, people what you call had a strategy. They implemented a program called the Speak Up program. The Speak Up program. What is the Speak Up program? Where nurses and others were told, you're not going to be punished when there is a mistake. You can speak up. You can tell the doctor. You can tell the attending that they are making a mistake, so that you can prevent the mistake. Now that was nice, yeah. But if the organization's culture does not allow, in the past has not allowed them to not be punished for speaking up or not taking any action, then chances are that they are not going to speak up. And it took a long, long time for them to speak up, right? So clearly, culture can be harmful if culture can harm the growth or implementation of patient safety. And a culture where you are in denial, where you don't disclose medical errors, where you don't address patients appropriately, of course, it's going to harm the institution and the institution's reputation.
Thank you for your
Are you happy?
explanation.
Okay. Are you happy, Miss Rara?
Yes, thank you.
Okay. Thank you very much, Professor Cyrus and Rara. Yes, there is a question. Good morning, Professor. My name is Rafi. Let me ask you my question about adaptive work that is implemented in CISP goals, namely to improve safety culture. How can cubes be applied when there is a dynamic change of culture?
Right. Good question, Rafi. So let me ask you, what do you mean by dynamic change of culture? Can I ask you what you mean by dynamic change of culture?
Rafi?
Yes, Professor. Okay, ya Bapak. Apakah
Yes.
suara saya terdengar?
Yes, ya. Saya bisa mendengar suaranya. What is the dynamic change of culture, Rafi? Definisinya apa ini?
Okay. I mean, Professor, we know that the globalization, modernization, make change of the culture of people. Bapak saya pakai bahasa Indonesia mau nggih?
Ya, silakan.
Maksud saya itu begini, Bapak. Dulu kan ketika sebelum adanya modernisasi, globalisasi, itu kan orang-orang langsung misalkan datang ke puskesmas atau datang ke rumah sakit. Nah, dengan adanya modernisasi, globalisasi ini kan orang-orang menggunakan HP untuk berkomunikasi, menggunakan HP untuk misalkan memesan antrian tiket di rumah sakit itu kan sebagian dari perubahan kebudayaan itu sendiri, gitu, Pak.
Okay.
Jadi itu maksud saya.
Okay. Okay, Professor Sari, I would like to try to translate what does Rafi means about the dynamic change. As you know, people using their mobile phone to connect with the health centers and healthcare, other healthcares. And they also have media. Lately they use media for like a telemedicine or something. Then that is the meaning of the dynamic change of the culture, as Rafi said. Is that any impact for the safety culture?
Absolutely, absolutely. So, good question, Rafi. I'm glad I asked the question because I would have thought of something totally different. But thank you for clarifying. So, it means that there is more adaptive work for the leaders, not just within the institution, but outside the institution. It means you need what you call more capacity for adaptive work because you are not only limited to patients being treated within your hospital, you are also addressing the PR and the perceptions of people outside of the institution. So it's more adaptive work. It's more capacity for adaptive work. It means you probably need to have employees have a culture that what you call addresses some of the issues that and expectations from patients outside of the hospital as well. So clearly there is more work. On another level, the more the channels for delivery of care, the greater the opportunities for error. So, and because miscommunication can occur when there are different technology platforms, different approaches, and what your doctor can see and visualize you when you are in the office versus with telemedicine may miss some things, the inability to do certain lab tests, etc. So clearly, telemedicine is good, but it needs to be approached with caution. So there needs to be culture around what sort of things in the institution are okay to pursue telemedicine with. So I don't know if that answers your question, but there's more adaptive work. It's not confined to institution, beyond institution. Okay, I think there are a few more questions.
Yes, there's a few more questions from Muhammad Rafli Ali Abdillah. What are the factors that fail to implement the program in improving safety patients' care? Then what is the strategy enhancing a good culture of cooperation delivering health service through effective approach and communication to meet patient need so as to improve quality and patient safety? I think it's a good question, Prof.
Yeah,
yes,
it's a good question. It's a good question. It's a good question. So the first thing I said is, if you see, the first thing is leadership commitment. If leaders are not bought into a program, they think this is a flavor of the month. It's like this month, this is the ice cream. Next month, there's some other program that comes and it's just, then if you don't have good leadership buy-in, no program is going to succeed or sustain. So leadership buy-in is important. To an interdisciplinary team. So you don't want just doctors running a CUSP program. This is truly interdisciplinary work. Patient care is interdisciplinary. Everybody needs to acknowledge the role and contribution of every healthcare professional. And so it needs to be interdisciplinary. Third, not having an executive adopt the unit. Yeah, you need somebody to amplify the voice of people because they're way down in the weeds, So you want somebody to be adopting the unit and taking it as their baby. So those are important aspects for success of any safety program, not just this safety program, but we think that is important. And communication is key. Communication needs to be bi-directional. It cannot be just one direction. Most of the times when I do organizational assessments, when there is a mistake, it's because I said this, the doctor said this, the nurse does not question, there is no backward questioning, there is no, and so you keep going down and then there's a mistake. So communication approaches need to change, which needs to be frank, need to be honest, needs to be transparent, where every healthcare professional is empowered to ask the question or ask, why are we doing this? So I don't know if that answers your questions, Mr. Ruffley.
Mr. Rafli?
Thank you.
Yeah. Yeah, I think it answer your question, Mr. Rafli. Yeah. Leadership, collaboration, transparent, amplifying the voice into the subunit. Is that so, Professor Cyrus?
Yes, yes, exactly. You nicely captured it.
Yeah. Okay, I would like to continue with the next questions from my colleagues. Dr. Muhammad Hood. I would like to introduce Dr. Hood. He is a senior OBGYN. He also, what is that? Interesting in the maternal health program, safety maternal health program. As you know, in Indonesia, we have a burden of high maternal mortality. And from this question is actually how to make people speak up about the program. To campaign for the program, not to blaming culture and to prevent the blaming culture. Because in Indonesia is a paternalistic culture, and how to solve it. I think that is question. Or I would like to invite Dr. Hood to speak up. Dr. Hood?
Yeah, sure.
Yes. Dr. Hood? Oh, no. Yes. Maybe you can answer the question, Professor Cyrus.
Sure. So Dr. Hood, let me just mention this question is worth its weight in gold, because to change culture, which is embedded, in deep roots and history, is not easy. I can tell you, I don't have all the answers, but I know what was done in the United States, in Australia, in New Zealand, in United Kingdom. Believe it or not, medicine in Western countries is not very different. It's still paternalistic. An attending what you call has more power than a resident, then who has more power than a senior resident, and there is a hierarchy that what you call limits what kind of communication and what kind of culture can be there. So it is true that paternalism is there, maybe more so in Indonesia, but it's still there in the West in some ways. So there's not much of a difference. So in the United States, what they did was they knew people would not speak up. So they came up with anonymous reporting systems based on the airline industry. Every airline industry has a aviation safety reporting system where the pilots or others can actually report the errors in a computer in anonymous ways. So hospitals started with anonymous reporting systems, which you don't have to mention your name, you don't have to mention where you're reporting from, but tell us, what mistake or what is likely to occur, or where you see a hazard, or where you see a risk, or what can we do to, or is there somebody who's at high risk behavior. So they have anonymous reporting systems, and they collect the data, they analyze the data, and then they take it to address some of those problems. So that's one. Two, safety reporting systems are being encouraged in these countries, and the government is actually making payments for people who report on mistakes, at least in the first few years. If hospitals report mistakes or report errors, because we have to change the culture. They get paid, a certain amount of money to report the errors. Yes, it's odd, but incentives are needed. So I don't have very good answers, but it takes a lot of work to go through this paternalistic culture. So I don't know if that answers your question, but to the extent possible, there's only one more thing I'd ask. Punitiveness, you need to take away punitive behavior. What does that mean? You don't want to punish people who speak up. The moment you punish people who speak up, you're going to stop any communication. So instead, people are being rewarded in the United States for reporting behaviors. So you need to think about changing the system to say, we'll not take it personally. Nobody will be fired. Nobody will lose their jobs, but we want you to tell us what's going wrong in our institution, and your job will be protected. I don't know if that helps.
Okay, thank you very much, Professor Cyrus. I would like to move to other question, and I would like to invite Elizabeth Tasya Octavianus Tarigan, who has raised hand. Elizabeth, can you speak up?
Okay, can everyone hear my voice?
Yes, I
Okay.
can hear your voice.
Okay, so good morning, everyone, and hello, Professor Cyrus. It's a pleasure to meet you. My name is Elizabeth Tasya Octavianus Tarigan from the Faculty of Public Health, University of Erlangga, and I have a question to ask. On your presentation, you said that to start a program or organizations, we need leadership supports. Based on your experience, maybe you can share with us how to build a good attitude of a leader and how to engage your team so the work or program or organizations can work well. That's it. Thank you very much, Mr.
Thank you, Elizabeth. A very important question. Yeah. So how do you convince a leader? How do you get buy-in from a leader? Because leadership is important. I have seen that there are times when you need to tell stories to leaders that work better. There are times when data and facts and figures work for leaders. You need to take numbers and you need to show faces of people and things and harm that has occurred. I need to show that this is a big problem. It's a problem that is huge, that needs to be addressed, that affects the reputation. It also is about, appealing to the leader that it is not going to, we are going to test it. We're going to take small baby steps. We are not talking about a large program. Leaders often worry about the risks. They often worry about the risks. They do a risk reward, what we call ratio. What's the risk? What's the reward? And if they see more rewards and less risks, then they are usually favored programs. So you can say, we're going to take small baby steps. We're not going to do this in all the departments, but why don't we start with ICUs, or why don't we start with operating rooms where the problem is maybe the greatest, or, so why can we start with OBGYN for that matter? Because we have a huge problem. And even if we see a little improvement, then we can think of moving on. So I don't know if that helps, but you want to show that then you want to say, also leadership needs to be sold that there is capacity, there is capability, and there is real commitment in the department to address this. So it's how you sell it to the leader, how you get the leader to trust you, and how the leader agrees to the idea that there is more rewards than risks associated with this program. Yeah.
Okay, thank you very much, Professor Cyrus.
Welcome. A good question.
Thank you, Elizabeth. I have a few more questions, Professor, from the audience. This is from Fini, the Master of Pharmacy students. My question is, a culture of closely related to the type of leadership? This is interesting question. The culture in the organizations closely related to the type of leadership.
The answer is yes. And there are different styles of leaders. There is the autocratic style of a leader, charisma, top down. big voice, charismatic male, white male, as they say in the United States, huge, tall, who's what you call a dominant leader. There's another one that is an influential leader. So if you, there are several styles of leaders, and there's that you can do assessments on leadership styles that are dominant, influencers, steady, or cautious leaders. And depending on the style of the leader, the culture will be spread across the organization. So yes, the answer is true. Leaders with certain styles can certainly influence the culture in certain ways, good and bad, both. So yes, that's true.
Okay.
Good question.
Thank you, Professor. Because we have a limited time, I would like to invite someone who has raised her hand, Mr. Haidar. After that, I would like to invite our chief of the program, Ibu Inga. Yes, Mr. Haidar, yes, can you unmute yourself and ask question to the directly to the Professor Cyrus?
Yeah, thank you for the chance. Sorry, do you guys hear my voice?
Yes, clearly.
Loud and clear.
Okay, thank you for the chance. Good morning, Professor Cyrus. Okay, speaking of culture, you said that we need to bring culture, for example, the usage of national language as formal language when the medical workers communicate with patients. Meanwhile, Indonesia has a lot of cultures and language in every region, or let's say traditional language. So the question is, do you think that it's better to speak traditional, which is informal, than national language? Maybe to make chemistry between medical workers and patient. That's the question. Thank you.
Thank you, Mr. Haidar. Please, please, Professor Cyrus.
Sure. So the answer is yes. Think about culture as something where you want to build a family, a unit as a family. What do you feel most comfortable speaking at home? If you consider your workplace to be your home, you want to be comfortable with each other and not have an artificial view. Because so in some ways the answer is yes, a qualified yes. You want to feel at home, you want to feel comfortable, you want to make sure that you communicate with the patients in a language that they understand, they prefer, that they most connect with. Because at the end, medical care is not just physical, right? It's also emotional, it's at a different level. And if you are speaking in a language that is not necessarily what they usually speak or at home, clearly it can have a different connotation. So yes, indeed, a cohesive, integrated, warm culture of care begins with a language, not just language, what is spoken, because a lot of it is not spoken. Informal communication is, if you go to a communication class, they will say 60% is informal communication. Yeah, 40% is verbal communication. There's also the signs, the languages, the attire, what you wear, etc. So yes, language has a role, but also your facial features, how you treat patients, how you respond to their requests, their verbal and facial expressions. All that also has a role to play.
Okay, thank you, Professor Cyrus, because we reach, we have a limited time, and the last is from our chief research group of patient safety. I would like to invite Ibu Inga. Please, Ibu Inga, time is yours.
No, thank you, Dr. Arjan. Actually, I have one last question. If I may, I would like to do the share screen because I think this one is very interesting. Wait, okay. So, Prof. Cyrus, I come across the HRQ website, and I see this one, yeah, the result of this program, how this program reduce so many infection in so many places. So my question is, how this program could be implemented in 700 hospital or more than 1,000 ICU in the United States. So is there any government rules or how? Thank you.
Sure, good question. I was involved in that ICU with Peter Pronovost, so I was involved in that, where all the ICUs in a certain state adopted the CUSP program. The state was Michigan. That was the first state in the United States that what happened was every state has a hospital association. And in this case, the State Hospital Association came to know about the CUSP program success at Hopkins and got in touch with Peter Pronovost, who was the head of the Armstrong Institute and who came up with this particular program prototype at Johns Hopkins, who you saw speak at the Josie King, And so there was a partnership, there was money that was set aside. Every ICU signed on. It became what we call a collaborative. These are called quality improvement collaboratives, where hospitals and units who have the same problem, who seem to understand, they reach across and form a collaborative to track bloodstream infections. And they all got together, and then they invited the team from Johns Hopkins to come to the state to present. And then they signed a contract for whatever funds to support the implementation, the training. There was a training of the trainers workshop, because you can't, you need to train. So people from the state, they flew in to Johns Hopkins. They spent quite some time. They did rounds and understood how the program works. And then there was always a quality improvement collaborative. So for 18 months, there were meetings with the trainers, with telephones and not Zoom. That time there was no Zoom, but they were talking about what they're doing, what problems they have, and they implemented the program. There's a lot of publications, and they were without infections in all the ICUs for almost 18 months, bloodstream infections. So if you want, it is remarkable that the program worked for 18 months continuously without a single bloodstream infection in all the ICUs sustained. And that study, I think, was published in the New England Journal of Medicine.
Thank
Great.
you. Yeah. I'm just thinking
Yes.
whether this kind of program could be implemented in Indonesia. And you say that there's a collaboration with the hospital association in each state. So actually, in each province, we do have the hospital association, but we don't know whether this similar type of collaboration could be adopted in Indonesia. Thank you so much for your time. Thank you, Dr. Adian.
Thank you so much. Thank you. Thank you
Thank
for
you,
having
Kim.
me. I truly appreciate that. Yeah. Thank you so much, Dr. Adrian.
Yeah. We are very grateful to have you, Professor, and we are thank you for your time and your lecture. It is very, it is beneficial for us. Yes. Is there anything you want to say, Professor?
No, I just want to say that I'm happy to send material about the success of this CUSP program. If anybody's interested or any questions they have, they can send it to Professor Inge, and I am happy to give any information that is there, because at the end of the day, you want to move on, you want to try this. If you want to try this, all the tools are available free of charge, because this was then taken over by the national government in the United States as a requirement. So they developed the tools, and because it was federal money, the US money, it's taxpayer money, it is available to anybody who wants to implement it or try it in their program. Yeah, all the guidance is available.
Thank you very much, Professor Cyrus. And
Thank you.
Yeah, from the audience, I would like to apologize that some question cannot be answered, but Professor Cyrus will deliver the material to the Professor Inge for the chief of the research group. Yeah. Okay.
Thank you.
Thank you very much, Professor Cyrus, and I would like to end this program, and thank you very much for the all audience. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you.
Waalaikumsalam.
Thank you.
Waalaikumsalam
Thank you, bro.
warahmatullahi. Thank you,
Thank you.
Prof. Cyrus.
Professor Cyrus.
Thank you.
Thank you, Professor.
Thank you,
Bu Inge, saya bisa live dulu ya.
Enggak, silakan di end.
Terima
Pak Iwan.
kasih.
Oke, matur nuwun.
Ya, terima kasih Bu Inge.
Terima
Nanti
kasih.
videonya saya upload di YouTube-nya FKM.
Oke,
Mas.
makasih. Adik-adik makasih ya pertanyaannya.